Good morning. Welcome to the Department of Psychiatry Grand Rounds presentation. My name is Dr. Robert Frierson, and I'm pleased to introduce today's speaker. Dr. Ethan Sharp was born and raised in Louisville, Kentucky, the third of four boys. He went to Martin Luther King Elementary and the No Middle School, followed by Trinity High School. His father completed a urology residency and his mother was a PharmD at the old General Hospital. Ethan obtained his BA degree in psychology from the University of South Carolina, where he graduated cum laude. Dr. Sharp has always had interest in charity, mentoring, and education. In high school, he tutored children with special needs and later did the same for U of L athletes. Over the past several years, he has been teaching first and second year medical students physical examination skills and working to educate third and fourth year students on illicit drug use and its clinical implications. Ethan's post-residency plans include working at the New Lease Clinic Drug Abuse and Psychiatric Disorders Treatment Center in South Louisville, and he is involved in the initiation of homeless outreach program there. It has been my pleasure to serve as Ethan's long-term supervisor for the past year. His dedication to the needy, the underprivileged, and those struggling with addiction can serve as a role model for us all. I have found him to be a skilled and empathic therapist, and more importantly, a fine young man. I am pleased that he has asked me to introduce him, so please welcome today's speaker, Dr. Ethan Sharp.
Thank you very much, Dr. Frierson. I appreciate everything that you've done. I've been working with Dr. Frierson for 6 years now, going back to medical school. And, Dr. Frierson or the residents call Dr. Frierson the human anxiolytic. And he's just got a phenomenal bedside manner and very, very knowledgeable and just such a great teacher. Also like to thank Dr. Al-Malik for the countless arguments, discussions, emphasis on critical thinking, Dr. Casey, department chair, as well as Dr. Wood for helping me out with this presentation, Dr. Kalil, Dr. Caudill, also Dr. Hiram Polk, general surgeon. He helped me to matriculate into medical school by giving me an opportunity to work in his research lab. All the other attendings, residents, medical students, faculty and staff, including social workers, nursing staff, technicians, custodial staff, security, pretty much everyone that I've interacted with at the medical school over the last 10 years, including the standardized patient program. Special shout out to the late Tony Williams, all the other SPs I've worked with over the years, the ACT community, Stephen Love and the Fancy Monkeys for helping keep me sane throughout this whole residency process. Of course, a big thank you to my entire family, including my late mother for instilling a strong sense of justice and morality within me. And also my dad for providing a lifetime of lessons from how to properly pull a weed, to establishing a work ethic that allowed me to get to and through medical school. And of course, thank you to my wife, Allison, our two dogs. Without her support, I don't think I would be in the position that I'm in today. So with that said, we'll go ahead and get started. Okay. And I have no disclosures. Nobody pays me to rep them. So essentially what we'll discuss today are trends in the evolution of mortality since 2000 in relation to the drug crisis, as well as a significant number and severity of comorbid conditions associated with illicit drug use. Hopefully by the end, we'll have some time to discuss solutions, but I definitely tried to cram way too much information into this presentation. So we'll see if we have enough time for that. So this is, essentially the real reason why I'm here. This is a close friend of mine that I was friends with since freshman year of high school, Will Grubbs. And unfortunately, Will valiantly battled, but eventually succumbed to the disease of addiction in April of 2020. And it would be a lot nicer if I could say that Will was the only person that I knew personally that had either lost their life or had, major life complications related to, this problem, this disease. And I just can't thank his parents enough, Jim and Susie Grubbs, who I think are on the call today, for allowing me to use his picture and his story, and kind of, let everybody know why this matter is so important to me. So, I know that it's not easy for them to do that, but being willing to share his story is, one of the only ways that we can decrease the stigma around addiction and help create the positive change that will help to curb the epidemic. So the drug epidemic is no longer just isolated to opiates. All types of drug-related deaths are increasing. While opiates remain the focus of this presentation and kind of the center of the drug epidemic, stimulants, benzos, synthetic drugs are also wreaking havoc on our society right now. Don't forget about tobacco and alcohol, which more so cause death by 1,000 cuts. Tobacco is implicated in roughly 1/5 of United States deaths, and alcohol causes about 100,000 deaths a year, 2.5 ratio of male to female, with about 2,200 overdose deaths and about 10,000 fatal car accidents. So newsflash, Americans are using illicit drugs. This survey represents non-institutionalized US civilians over the age of 12. There are 165 million persons who have used illicit drugs in their lifetime, with 66 million in the last year and 36 million in the last month. So let's review some general trends in overdose deaths. Prior to 2000, we had less than 20,000 overdose deaths per year. Things like HIV and AIDS, motor vehicle accidents, suicide and homicide all outpaced overdose deaths for decades. And then with this drug epidemic, we all of a sudden we're to a point where we're now seeing a decrease in life expectancy. We didn't see any decrease in life expectancy from 1950 until 1993, when it dropped 1/10 of a year related to homicides and HIV. And then again in 2015, you'll notice another little 1/10 of a year drop related to overdoses. But in the last year, 2020 compared to 2019, we've seen a decline of 1.8 years. And while part of that is related to COVID, there were 350,000 COVID deaths in 2020, but 93% of those were in people over 50 and 75% in people over 65. On the flip side of the 100,000 drug overdoses that caused death, over 90% occurred in patients under 64 and 75% occurred in patients under 50. And then we had a nearly 40% increase in overdose deaths between 2019 and 2021, making the historically worst drug crisis in world history even worse, with no real end in sight. Kentucky consistently ranks in the top 5 in terms of overdose rates in the country. And if you look at the top 10 causes of death in the United States from 2018, you see unintentional injuries as the leading cause of death from age 1 to age 44, killing about 167,000 people in 2018, with a reportedly over 200,000 in 2020. And in 2021, actually, we actually surpassed 100,000 overdose deaths. You can see on the very right side in the total column that unintentional poisoning is AKA overdose. And so that killed 64,000 in 2018, 100,000 in 2021. But again, there's possible addiction sequela included in that. 38,000 killed by motor vehicle accidents, 38,000 killed by unintentional falls, with that being the #1 cause of death in the elderly, and another 50,000 deaths by suicide. That's not to mention all the different effects on the heart, the liver, the kidney, the brain, or other chronic medical conditions that can be exacerbated by drug use. 2020, unintentional injuries were the number 4 cause of death, outpacing cerebrovascular disease and COPD. In 2021, drug overdoses by themselves are expected to surpass diabetes and all other unintentional injuries as the number 6 cause of death. And when you consider that the average years of life lost in a drug overdose is somewhere between 30 and 45 years, we're talking about 3 to 4.5 million years of life lost last year, with over 1 million people have died from this epidemic since 2000. So US drug overdoses represent roughly a fifth of the world's 500,000 overdose deaths. And though overdoses are not even in the top 10 causes of death globally, the problem with drug use seems to be metastasizing to nearly every continent, kind of morphing from an epidemic to a pandemic. And so the first couple of waves of the drug epidemic, more so related to opiates, prescription opiates and heroin, affected white Americans more severely. However, the surge in fentanyl-related deaths since 2015 is disproportionately affecting communities of color, with the highest increases in death rates in 2020 in Black, Hispanic, American Indian, Alaskan Native, and Asian Americans, all of which experience higher rates of overdose deaths than white populations. And this was absolutely astounding to me. Black Americans saw the largest decrease in life expectancy of these groups from 2019 to 2020 of nearly 3 years. Not only is this problem causing widespread mortality and morbidity, the cost, or estimated cost, is astounding, at over $1 trillion per year in the United States and about $25 billion per year in Kentucky. So we've seen a consistent increase in overdose deaths since the late 90s, early 2000s, with multiple waves. First, an increase in the prescribing of opiates and benzos and other prescription pills. Second, a rise of Mexican black tar heroin in the early 2010s, followed by an increase in Chinese imported fentanyl. And then what I consider a fourth wave in the last couple of years related to the pandemic. And it actually all started decades prior to the increase in opiate prescribing. We saw in the 1970s, 80s, and 90s this pain revolution, or the idea that untreated or undertreated pain was violating ethical principles of medicine. And this became pervasive in the medical community, trickled its way into medical school curriculums and hospitals. And the notion of treating pain as a fifth vital sign was supported and pushed by the American Pain Society, the Veterans Health Administration, and the Joint Commission. We started using patient self-reported pain scales as opposed to our own medical expertise. And as the revolution hit its stride in the 1990s, Purdue Pharmaceuticals rolled out a new drug, OxyContin, touted as an extended release version of MS Contin that smoothly provided pain relief for 12 hours and caused addiction in less than 1% of patients. So where did that notion come from? Well, a big influential piece of literature, one of the most influential of all time, in my opinion, made a hell of a negative impact on the medical community and its patient population. Herschel Jick was an academic drug researcher and Harvard graduate who didn't have any clinical experience. Jane Porter, not to be confused with Tarzan's Jane Porter, was a graduate student that was working with him via the Boston Collaborative Drug Surveillance Program. And they collaborated on a chart review and wrote this 1 paragraph, 5-sentence, 100-word letter to the editor that was published in the New England Journal of Medicine, claiming that out of 12,000 hospitalized patients that obtained at least one narcotic preparation, there were only 4 cases of reasonably well-documented addiction in patients without a history of addiction, and only 1 case of major addiction. What a landmark review. So Purdue down the road turned this into the perfect weapon for Purdue and other pharmaceutical companies to latch onto. Jick, in a 2017 interview, stated, "If I knew then what I know now, I never would have published it." And so look at what happens over the next 3 decades in terms of the number of times this paper is cited by other papers. Astounding, over 200 citations between 1996 and 2004, with only 3 negations of what the paper was claiming. Somebody's still affirming this study as of 2016. And so retrospective analyses have shown that these were inpatients. They received all the opiates in the hospital, and they were not discharged with an opiate prescription. So of course they didn't get addicted because, 1, they didn't have any access to opiates after discharge, and 2, they weren't followed up with after discharge. It wasn't until 2017 that the New England Journal finally added a clause above the letter, stating that for reasons of public health, readers should be aware that this letter has been heavily and uncritically cited as evidence that addiction is rare with opioid therapy. These are a few excerpts from other papers that cited Porter and Jick's evidence. I like how the last claim incorrectly identifies the index study population as cancer patients. The VA, Department of Defense, in their 2017 clinical practice guidelines for opioid therapy for chronic pain, cited that long-term opiate treatment does not have evidence for long-term efficacy, and also stated that no study using opiates for chronic pain had lasted longer than 16 weeks, as well as citing that actual validated studies on the risk of addiction report numbers closer to 25 or 30%. Now, Purdue catches the most heat due to the aggressive, profit-driven, later found to be illegal, what I would say is pretty immoral marketing of this drug. This is one example of how they manipulated data. In this one, they manipulated the plasma concentration on the y-axis. You can see the graph is morphed there to make OxyContin's release appear more consistent over time. And they were also aware of internal data that this drug was being misused, that users were dissolving the exterior coating in their mouths and then crushing the remaining pill and snorting it or ingesting it, effectively turning it into an immediate release drug. On the bottom, you've got IR, or immediate release oxycodone. And so this is what the user was more likely experiencing. Now, Purdue was not the only bad actor contributing to the epidemic. It took several other opiate makers, including Spec GX, a subsidiary of Mallinckrodt, that makes generic oxy and hydrocodone, as well as Actavis, which is now Teva and makes Norco, and then several distributors, including McKesson, Walgreens, CVS, Walmart. And so we see sales of opiates skyrocket as America develops our latest national pastime. And while this is going on, Purdue is conducting more than 40 national pain management and speaker training conferences in and around their test market of Appalachia. And these are all expenses paid trips at resorts in Florida, Arizona, California, even Hawaii between 1996 and 2001, where over 5,000 physicians, mostly primary care, pharmacists and nurses attended. And so sales of oxycodone skyrocketed from 40 million in 1996 to more than 1 billion in 2001, out earning Viagra. We start to see a disturbing trend in prescribing and diversion. The House Energy and Commerce Committee, while investigating the epidemic in 2019, found that in the decade between 2006 and 2016, in Williamson, West Virginia, a small town on the Kentucky border in Hatfield-McCoy territory, 21 million pain pills were dispensed to a population of 3,200 people in a place that had 2 pharmacies. That amounts to about 6,500 pills per resident, or roughly 2 pills per day for 10 years for every single resident of that county. Not only does the number of prescriptions see a steep rise, but all of a sudden, Americans are requiring higher dosages to manage our pain. Ironically, we report increasing levels of severe, moderate, and mild chronic pain from 1998 to 2010 as dosages increase. Purdue's solution to this was to up the dosage. They actually, at one point, made a 160 milligram oxycodone pill, which is just an absurd amount of opiate pain medicine to be in one pill. And then later they kind of backtracked on the fact that their medicine lasted 12 hours. They started recommending using it every 8 hours, and then that became every 6 hours. So we see the emergence of pill mills throughout Appalachia and surrounding states and regions, with Kentucky and many border states having the highest prescription painkiller rates in the world. You had previously red flagged physicians, whether that be from insurance fraud, medical malpractice, their own issues with addiction, or even a couple of reports of inappropriate sexual relationships with patients, as well as kind of morally aloof entrepreneurs that would open clinics, providers spending regularly less than 5 minutes with a patient, prescribing Oxycontin to dozens, if not hundreds of patients per day, mostly for minor ailments. If you've watched The Pharmacist on Netflix, you'll remember Dr. Jackie Cleggett, who was operating a pain clinic in Louisiana, where this pharmacist was living, with lines of patients extending out the door in the middle of the night. She later admitted to her own addiction to opiates, but it just points out that there were no limits on how many prescriptions a doctor could write, nor any way to prevent multiple visits to multiple providers. So Appalachia and the surrounding areas were particularly vulnerable because of high unemployment, high poverty rates, and the fact that Purdue selectively rolled out Oxycontin in these areas. You had a lot of factory jobs that dried up in the 1980s and 90s. I thought it was pretty interesting to hear that 99% of the Appalachian population owns less than half of the land in Appalachia. And so you have the emergence of hillbilly entrepreneurs, some who are just looking for a way to support their families, going around scooping up addicts, driving them to multiple doctors and pharmacies, and creating this secondary market for resale and distribution of pain pills. And so you see the amount of morphine equivalents increase drastically between 1995 and 2010. And so this 2019 study of 130,000 post-op surgical patients in 3 countries for these minor surgical procedures, a lap cholecystectomy, lap appendectomy, meniscus repair, and breast excision, we had 76% of these patients filling opioid prescriptions within the first 7 days, compared to 11% in Sweden. I don't know what they're doing to manage pain in Sweden, but it appears that they're using less potential harm medications or treatments in order to do so. The average morphine equivalence prescribed in the United States is also significantly higher. And you can see on the right here, this is University of Michigan's post-surgical opiate guidelines in response to the opioid epidemic. And for comparison's sake, for these procedures, they're recommending 10 5 milligram oxycodone tablets, whereas the average 250 morphine equivalents averages out to roughly 35 5 milligram oxycodone pills. So why is that so important? Well, because later studies have shown that the risk of addiction increases drastically past a short-term 5-day opiate supply, which with a 5-day supply, the risk of continued use or dependence at 1 year is a little bit less than 10%, and at 3 years, a little bit less than 5%. This risk with a 30-day prescription increases to over 40% for 1 year continued use and over 20% for 3-year continued use. So pre-1996, we have opiate deaths overdose deaths of about 1,000 per year. And then with pill mills and the trickle down secondary opiate market and the arrival of OxyContin, AKA hillbilly heroin, watch what happens over the next decade. And so back to 2006, you've got the crude cost without insurance of 180 milligram OxyContin pills was about $1,000. However, with a Medicaid card, the copay was for 100 pills was less than $5. So you've got a black market value of $1 per milligram for OxyContin. And so a 100 pill prescription had a street value of $8,000. Diversion became rampant, and nationwide, we see this 33% increase from 2003 to 2006, centered around Appalachia. In 2009, we see the epidemic continue to spread. There were some whistleblowers that existed within Purdue and within government agencies such as the DEA and the FDA, but they tended to be stymied. If you'd like a little bit more information on that, I'd encourage you to look into DopeSick. Nice passive way to learn about the role of big pharma and the legal battles that surrounded the opiate epidemic. And so as this crisis worsened, our government started to shut down pill mills and started to install prescription drug monitoring programs, restricting doctor shopping, restricting the available oxycodone to the secondary market. Not all states implemented these programs expeditiously. And so new mills opened up in Florida, and Appalachians started to make pilgrimages down to Florida, scooping up the local addicts, providing transportation and the copay for their prescription in exchange for half or more of their prescription, and then bringing back hundreds to thousands of pills to their community. And so by 2012, heroin was the cheapest it had been since the 1970s. And the heroin epidemic kind of started in the West as sons of subsistent Mexican sugarcane farmers took advantage of the fact that poppy grew very well in their region of Jalisco in Mexico, and they started transporting black tar heroin into the United States. This change occurred around 2012. And Mexico increasingly was the primary source of heroin influx into the US, jumping from about 50% of production to over 90% between 2013 and 2015. The first markets they took over were a little bit closer to the border in the West. And this part really hit young people who use drugs that relied on that secondary opiate prescription market the hardest. When they could no longer get those due to the restrictions. And so while Appalachia is still mostly relying on secondary prescriptions, secondary market prescriptions, the second wave heroin with resultant IV drug use hits the West hard. The Jalisco cartel started by exporting heroin to New Mexico, Colorado, Arizona, California, and pockets of the Pacific Northwest. Once they had conquered one market or one city, they then moved east across the United States. Took several years for the DEA to realize these were not isolated small operations, but rather an interconnected national business network with new outposts established by providing free samples to addicts outside of detox facilities, halfway houses, homeless shelters. Heroin was about a quarter of the cost and 10 times the potency. And this always blows my mind because I started medical school in 2014 and it didn't seem like the problem could get any worse. And we have more than doubled this number since then. Highly recommend Dreamland by Sam Quinones if you want to learn more about the prescription opiate and heroin waves of the epidemic. Told from several different perspectives. This slide I just wanted to include to emphasize how deadly heroin addiction is. It's one of the only longitudinal studies of heroin addicts. with about 600 followed between 1964 and 1997. About 90% of them were followed up on, and it was found that half were deceased, 10% were lost to follow-up, and only 20% of the original sample remained abstinent. Kentucky, again, hit particularly hard, not just by overdose deaths, but also by the sequela of IV drug use. And just as heroin deaths start to taper off, the crisis evolves again with increased availability of China-produced fentanyl, and the epidemic worsens again. The third wave hit around 2014, 2015, causing another massive surge in overdose deaths from 50 to 100,000. And it does not look like it has peaked just yet. This is a visual representation of the amount of heroin, fentanyl, and carfentanil that could cause a fatal overdose. The estimated lethal dose of uncut heroin is 20 to 30 milligrams. Of uncut fentanyl is 1 to 2 milligrams. And of uncut carfentanil, which is used to tranquilize elephants, of 0.01 to 0.02 milligrams. This just shows the number of DEA seizures of fentanyl from 2001 to 2016. And in New York City, from 2000 to 2012, fentanyl was involved in about 2% of overdose deaths. As of 2017, fentanyl has completely contaminated the drug supply, involved in about 60% of all New York City overdose deaths. Studies on whether patients are knowingly seeking out fentanyl were pretty hard to find, but a 2019 survey of 308 opioid withdrawal inpatients in Baltimore, Boston, and Providence showed that only about 25% of those probably more severe opiate use disorder patients preferred fentanyl. I think we can safely assume that those persons seeking out benzodiazepines or cocaine and other non-opiate drugs are much more likely to be actively trying to avoid fentanyl, but they're not. While the number of cocaine-only deaths has not significantly increased since 2000, cocaine contaminated with fentanyl and its analogs have pushed cocaine deaths over 20,000 per year, estimated in 2021. Benzodiazepines, we see a similar result, with benzo-only deaths remaining consistently low from 2000 to 2020. But due to the synergistic effect on respiratory depression when prescription opiates and benzos are mixed, we first see a rise with the first wave in the early 2000s. Then the number of overdose deaths doubles from 2014 to 2020, with fentanyl mostly contaminating the benzo supply. Meth-related deaths are slightly more complex. There are kind of two factors here. One is the rise of fentanyl contamination, and the other is due to the increased purity and widespread availability of methamphetamine, which is another product that the Mexican cartels, including the Jalisco and the Sinaloa cartels, have taken a monopoly over the meth trade. We're talking about almost 25,000 deaths a year related to meth. And so more than half of drug overdose deaths in 2020 came from a contaminated supply. And then we had this kind of what I consider a fourth wave related to COVID hit. And we saw a 55% increase in Kentucky in fatal overdoses over the first year of COVID from April 2020 to 2021. Trailing only Vermont, which was at 70%, and West Virginia at 62%. Again, primarily due to the increased availability and contamination with fentanyl. So where is all this fentanyl coming from? As I mentioned earlier, according to the DEA, China remains the primary country of origin for illicitly manufactured fentanyl. In 2018, the Chinese government did schedule fentanyl, but producers then shifted their practice to trafficking fentanyl precursors and analogs, which were still legal, to the United States, Canada, and Mexico. The strained relationship between the US and China is likely contributing to a lack of enforcement of the exportation. But at the same time, we're talking about a microscopic product that is extremely lightweight, odorless, and easily hidden from authorities. And so what you see on the screen here is one of the scariest parts of this fourth wave. These are counterfeit pills that are made with a pill press and pill molds. In our consumer culture, in the age of information, in the advent of the dark web, patients can obtain benzo prescriptions with or without a provider's sign off. Unfortunately, when these pills are bought off the internet or from an illicit drug dealer, there's the risk of death with just one pill, regardless of whether there's intent to use fentanyl or not. Up top, if you can't tell, the left one is the fake Xanax and the right one is the real Xanax. And then we've also seen a reemergence of illicit oxycodone with over 10 million pills seized in 2021, according to the DEA. So let's take a closer look at how these are made. These are just simple internet searches, and you can see that these pill presses are widely available, easily bought. Dealers use these to combine fentanyl with other drugs or filler substances in order to increase their potency due to the low cost and high return and easy ability to transport fentanyl. And you can see here, they're even marketing on their website how to evade customs. So dealers can also purchase customized molds for $40 to $80 so that the pills appear very similar to the real pharmaceutical grade prescription. They use psychoactive and non-psychoactive fillers such as acetaminophen, laxatives, starch, atropine, xylazine, hundreds of other fillers in order to cut costs and or prolong the effects of the fentanyl. And then this mixture is then pressed into the mold and illicit benzos, opiates, and other pills are made. Unfortunately, there is little to no regulation or punishment for buying or possessing these presses or molds by themselves, even though there's really very few other theoretical uses of them. Another problem that has been emerging over the last few years are designer drugs. We have novice street chemists that are altering the chemical structure and properties of an existing compound, partly because those compounds are not illegal. They are kind of in this gray area between legal and illegal. But this European study of almost 10,000 drug-related deaths with a full toxicology report from 2019, I believe, 2016, shows that over 1,000 of them involved at least one new psychoactive substance. Synthetic cathinones are another kind of emerging issue and are increasingly problematic, causing manic-like behaviors, tachycardia, psychosis, and have also been implicated in several deaths. In Louisville, we may be a little bit more familiar with synthetic marijuana, aka spice. It can cause central nervous system agitation, coma, seizures. Anecdotally, I've seen several patients who cannot even remember their names when they're intoxicated on this. And unfortunately, these are sold legally in head shops, gas stations, convenience stores. And it's an absolutely horrible name for the substance, as marijuana makes it sound relatively benign. But names like Boomtown Mamba, which is my personal favorite, but they give a false impression to the user. What probably scares me the most are that teenagers, could consider this comparable to regular marijuana. They could use it out of curiosity. They could use it to evade drug tests. And the reality about this substance is that spice is like a box of chocolates. You really don't know what you're going to get because this chemical structure When it does cause problems or cause deaths, the FDA comes back around and bans it. But then the makers just tweak one little molecule, and then it's got a different chemical structure and different effects that we don't find out about until afterwards. So April of 2018, they found a significant supply of synthetic marijuana that was laced with brodifacoum, which is thought to prolong the psychoactive effects of spice. Dr. Love the other day, unsolicited, told me in his first couple of months of residency that he had an internal bleeding patient after exposure to spice, likely related to this same drug supplier that affected Illinois patients in a major way, but also affected 7 other states. Again, as we discussed with the designer drugs, it's not just deaths, but a whole host of other medical and psychiatric comorbidities that go hand in hand with addiction. There's no way to cover all the sequela or the morbidity of drug addiction, but I'll try to focus on the major complications. This is especially evidenced by what was happening during COVID in emergency departments. And so this study coming out of JAMA Psych in 2021 shows the total number of US emergency department visits at the start of the pandemic dropped from about 8 million to less than 5 million in April and remained a little bit lower through September. Despite about a 40% drop in the total number of visits in the first month of the pandemic, overdose numbers remained consistent with pre-pandemic numbers. Then when people started coming back to the emergency departments, overdose rates sharply increased. And so you can see here that blue line is mental health conditions, and then the dark line below it is all drug overdoses. And this represents the rate of drug overdoses compared to total ED visits, which nearly doubled between March of 2020 and May of 2020. Per usual, we saw a worse than national trend in Kentucky during COVID, with total ED visits decreasing significantly in the first 6 months. And the rates of overdose-related ED visits compared to total ED visits nearly tripled in the first 2 months of the pandemic and remained nearly double their 2019 rates throughout the rest of this study. There's even literature that substance use puts you at a higher relative risk of contracting COVID. And so we start to see, or we'll transition here to some other morbidity associated with illicit drug use. So the mortality in IV drug use is about 22 times greater than age-adjusted controls. And there were reported 1 million active drug users in the United States in the last year. So this is a list of complications from IV drug use published in an emergency medicine textbook. We'll kind of focus on HIV, HCV, and endocarditis, but also briefly mention some changes in the rates of osteomyelitis, skin and soft tissue infections, and central nervous system abscesses. So people who inject drugs are 22 times more likely to contract HIV. Of the roughly 12 million people globally who inject drugs, there's about 2 million living with HIV. So most local folks will be aware of the Scott County HIV outbreak in 2015. And the epicenter of the town of Austin, Indiana, has about roughly 4,000, population of 4,000. It's only about 30 miles north of Louisville. In 2015, they registered 142 new cases of HIV. By 2017, they had linked over 215 cases to this outbreak. And to give you a point of comparison, the prior record high in new HIV cases per year in Scott County was 5. And they had seen a total of 3 from 2009 to 2013. And now you've got a town of 4,000 people where about 250 of them are infected with HIV. 8 out of the 10 of the most at-risk countries in the nation for HIV and hepatitis C are located in Kentucky, with 36 out of the top 100. And going kind of right hand in hand with HIV is hepatitis C, even more transmissible. Estimated that about half of IV drug users are positive for hepatitis C, and currently 90% of new cases are related to IV drug use. We have this graph showing that by 2013, Kentucky is number one, always number one when we don't want to be, and surrounded by all of the other Appalachian states, surrounding areas. West Virginia, Indiana, Tennessee round out the top four. Kentucky from 2009 to 2013 saw about a 700% increase in the rates of hepatitis C. And just to give you an idea of how deadly hepatitis C can be, this is a World Drug Report implicating Hep C in nearly 300,000 deaths globally, while HIV is associated with nearly 100,000 deaths, as well as significant disability and years of healthy life lost. These infections are obtained via sharing needles with afflicted persons. And this graphic, kind of tells you that we need to do a better job of educating our youths in regard to how to avoid those complications. Endocarditis mortality for untreated endocarditis is extremely high, approaching 50%. Morbidity is very high as well. And so let's take a real quick virtual tour of where bacteria go when they're injected. So the patient injects, and even if they have a clean needle, that bacteria from their skin, Staph aureus generally, that helps provide a barrier for our skin, can then, if they don't clean it beforehand, that can infect first their vein, as the first possible nidus of infection. And then it can travel to the right side of the heart. It can latch on to that tricuspid valve and or the pulmonic valve. And with each contraction and increase in pressure, there's the possibility of some or all of that vegetation breaking off. And so once it breaks off, all of a sudden it can go to the lungs, it can go to the right side of the heart, the mitral valve, attack the aortic valve, make its way into systemic circulation, and then find its way into coronary arteries, causing acute myocardial infarction, shooting into the brain, causing a stroke, can cause infarcts or abscesses in the kidneys, liver, spleen, colon, spine, skin, and joints. And so when we look at the prevalence of IV drug use in young adults, which is essentially another marker of endocarditis related to drug use, because these endocarditis generally does not affect people under 30 years old. You see that there were more than double the number of patients under 30, and the prevalence of IV drug use jumped from about 5 to 15% in comparison to all endocarditis from 2003 to 2016. Another national study of substance use disorder versus non-substance use disorder associated endocarditis showed an increased incidence of IV drug use related endocarditis, going from 15% of total to 30% of total endocarditis. In 2015, estimated expenditure of almost $2.5 billion compared, which is up from $1.6 billion. This is another retrospective cohort study using a huge database from over 800 private and academic hospitals, about 20% of total US hospital discharges. These are hospitalized over 18 with infectious diagnosis, and it just shows the rate of substance use related endocarditis increased from 1.6 to 3.6 per 100,000 persons, while the rate of non-substance use endocarditis decreased from 4.2 to 3.2 per 100,000. It's an estimated $33,000 per hospitalization, with roughly 12 to 13,000 total hospitalizations a year. and there goes another $500 million. Same as this is just related to the study on the last slide. Also showed that rates of IV drug use related osteomyelitis or infection of the bone doubled from 8 to 16% with roughly 22,000 per hospitalization. The rate of central nervous system abscesses increased from 15 to 24%. And the rate of skin and soft tissue infections, of which there's nearly 1 million per year, increased from 6.8 to 9.4%. And again, that predominant organism is Staph aureus. So outside of IV drug use, we also have, overdose that comes into the emergency department. It can range from, outcomes can range from an emergency department discharge to a prolonged ICU level hospital stay, depending on the degree of hypoxia experienced by the patient. So it's always been kind of fascinating to me, what are the effects of rapid severe hypoxia that is reversed prior to full brain death? What is the effect of less severe but prolonged overdose with, say, a respiratory rate of 3 to 6 breaths per minute? And also, do repeated subclinical overdoses lead to physical, cognitive, and emotional impairments? These are some examples by system. And remember, these are separate from IV drug use related comorbidities. This is a really interesting study from Columbia University, published in JAMA Psychiatry, of 75,000 adult Medicaid patients during the first year after a non-fatal opioid overdose. They expect 215 deaths in a population of 75,000, and this population saw over 5,000 deaths. Of those deaths, though, interestingly enough, only 50% were related to the substance itself. You had 13% related to circulatory system failure, 6% to respiratory problem, 6% to infectious cause with 3.5% HIV, 4% to suicide, 10% to cancer, 2% to cirrhosis, alcoholic liver disease, and 3.5% to digestive system issues. According to a 2020 study of roughly 1,400 opiate overdoses in the Annals of Emergency Medicine, about 25% had cardiopulmonary complications. And then also crack cocaine is particularly toxic to the lungs. This is another interesting study on 234 deceased opioid users, pointing out the fact that about 42% were found to have aspirated gastric contents, and 13% had fulminant aspiration or severe and acute aspiration. And the really interesting part is that these fulminant patients actually had significantly lower concentrations of opioid in their blood, which supports the notion that they may have actually died from aspiration or asphyxiation rather than presumed respiratory depression. Of 150,000 tuberculosis patients, about 30,000 reported substance use, which is more of a risk factor than immunocompromised HIV status. A 2008 to 2011 study in the country Georgia found a 26 times increased risk of tuberculosis with illicit drug use. This is some preliminary data by UCSF researchers presented at the AHA conference in 2021, comparing 24 million adult inpatient hospitalizations and ED visits from 2005 to 15, identifying about 100,000 meth use disorder, 50,000 cocaine use disorder, and 10,000 opiate use disorder cases. And they labeled risks of atrial fibrillation as 86% higher in meth users, 74% higher in opiate users, and 61% higher in cocaine users. These are some of the radiologic findings you can see with the toxic effects of cocaine and crack. The top left is a case of acute chest syndrome in a 49-year-old with progressive shortness of air and fever after an IV binge. The top right is a pneumomediastinum in a 28-year-old who presented with retrosternal pain. after smoking. The bottom left, you have a spontaneous left-sided pneumothorax in a 33-year-old from smoking, presented with chest pain. And then on the bottom right, you've got pulmonary fibrosis in a 38-year-old with a long-term crack smoking history. This is just a more comprehensive list of pulmonary complications of cocaine. And then we know that there are neurologic complications of intoxication and or withdrawal, including seizure disorders or epilepsy, with cocaine most likely to precipitate seizures, but also able to be precipitated by heroin, ecstasy, inhalants, stimulants, and synthetic cannabinoids, as well as benzo and alcohol withdrawal. But another kind of less recognized neurologic sequela is related to the brain experiencing these periods of sustained hypoxia. And so just to quickly review without getting too deep into the weeds, remember that the brain has high energy requirements and low energy reserves, has powerful cerebrovascular regulatory systems that assure that increases in blood flow are compensated compensate for low arterial oxygen content. And so the system fails when blood pressure declines and brain energy metabolism can rapidly collapse. The first thing that's affected are more complex functions like protein synthesis, spontaneous electrical activity, and then energy states begin to break down, cell membranes begin to depolarize, and all of this is an effort to protect vital regions to survival, such as the brainstem, while sacrificing higher order functioning areas of the brain. And so the most sensitive areas include these watershed zones, which include the external areas supplied by the ACA and MCA, or between the ACA and MCA, and then also between the MCA and PCA, as well as internal watershed areas around the globus pallidus. And again, there's all kinds of drug combinations that exacerbate or provide a synergistic effect with opioids, including benzos, alcohol, other sedative hypnotics, and GABAergics, as well as the whole CYP3A4 system. CYP3A4 is important because it breaks down fentanyl to norfentanyl. And so if, for example, you have an HIV patient who is also an illicit drug user, then you can potentially have inhibition of fentanyl breakdown and overdose caused by that drug-drug interaction. This is a study out of British Columbia of roughly 2,500 admissions for accidental opioid overdose over a 10-year period, with 3 to 4% experiencing encephalopathy. Another study on anoxic brain injury out of Quebec showed a 2020 rate of more than 4% in about 4,400 opioid-related hospitalizations. And these are some imaging findings. This is a 51-year-old female, history of chronic pain on a fentanyl patch that was found comatose in her home. She was resuscitated and intubated on site, transferred to the external hospital where she showed no focal neurologic deficits, but this unenhanced CT image showed almost symmetrical bilateral hypointensities of the globus pallidus in that internal watershed area. 3 weeks into her hospitalization, the patient developed progressive neuropsychiatric symptoms, including agitation and odd behavior. She was urinating in a trash can in other people's beds. This was later followed by psychomotor retardation, generalized apathy, and finally mutism, in addition to increased muscle tone with generalized rigidity and spontaneous myoclonus. And the MRI here shows bilateral basal ganglia necrosis. 5 weeks into the hospitalization, the patient's impairment remained mostly unchanged. The MRI here shows not only globus pallidus damage, but also symmetrical, extensive, marked diffusion restriction of the white matter that is primarily frontoparietal or more isolated to the external watershed areas. This is a follow-up MRI at 9 months. They do not comment on the patient's condition. They did say that she went to a neuro rehab, but you can see marked regression of the leukoencephalopathy with a remaining faint hyperintensity, predominantly in the parietal white matter of both hemispheres. And you can also see a slight enlargement of the ventricles, which could signify some atrophy had occurred. You also have several GI and GU complications. We'll review some of the radiology slides for these. This again is a more comprehensive list. This graph represents various ways that heroin can cause AKI. More implicated in AKI and rhabdomyolysis is cocaine use due to its potent vasoconstrictive properties. Prevalence studies show out of about 26,000 annual rhabdomyolysis cases, about a quarter of those are found in patients with cocaine use disorder. And then also the relative risk of end-stage renal disease with illicit drug use is about 19 times higher. This is an image of a cocaine-induced hepatotoxicity in a 41-year-old presenting with 2-day history of worsening right upper quadrant pain and elevated LFTs. This ultrasound shows decreased echogenicity of the hepatic parenchyma. This is a case of Fournier's gangrene in a 42-year-old who presents with scrotal and perineal pain after trying to pop an abscess in his scrotum after smoking crack. CT shows marked scrotal edema, soft tissue fluid, and gas that required emergency surgical debridement. This is a case of narcotic bowel syndrome in a 36-year-old chronic opioid user with the CT showing small bowel obstruction. And this is fecal impaction in a 69-year-old with an implanted pain pump for chronic back pain who presented multiple times a year with constipation. And the CT here shows severe fecal impaction involving almost the entire length of the colon. This is a renal complication, possibly related to that same 2018 synthetic cannabinoid cut with the vitamin K antagonist. This is seen in 2 patients. You can see a spontaneous hemorrhage with bilateral subcapsular hematomas. And the 39-year-old patient presented with hematuria, abdominal pain, and hypotension. There's a host of other difficult to quantify problems that are likely exacerbated by illicit drug use. We'll just kind of briefly review those. You've got depression and suicide, outcomes that are associated with prescription pill and IV drug use. Some overdoses are surely intentional, while some suicides and drug use are inevitably linked to that person's drug use. And you can see here the increased risk of suicidal thoughts in past year users of prescription or past year users with prescription opioid disorders. All of these are much higher than never users. You've got another 2012 national survey on drug use and health showing suicidal thoughts, intentions, and attempts are all increased. 6 times risk of suicide attempt, 4 times risk of serious thoughts and or a plan. Estimated that alcohol and people who use drugs have a 10 to 14 times higher risk of death by suicide. This one is one that maybe hits a little bit more close to home for the residents and attendings and medical students who are here. Methamphetamine has been more and more widely available with each passing year, and it's also become more and more potent. And so what we're seeing, I can't tell you how many patients I've seen in EPS who used meth for several months to several years, and then despite having long periods of sobriety, they still appear extremely paranoid, most of which are persecutory delusions. And so the meta-analysis or recent meta-analysis of the prevalence puts it at around 37%, with 30% still having some symptoms after 6 months of abstinence. This is a cool graphic comparing acute meth psychosis, chronic meth psychosis, and schizophrenia, which is commonly diagnosed after 6 months of symptoms because of the way that the DSM is formulated. A Thailand study of meth users, Southeast Asia has has a notorious bad problem with methamphetamines. But this Thailand study found that of all psychiatric hospital admissions, 10% were related to meth-induced psychosis, and almost 40% of those patients were diagnosed with schizophrenia due to persistent psychosis at 5-year follow-up. Have to mention neonatal abstinence syndrome. 2008, the rate of NAS in the US was less than 3 per 1,000 live births. As of 2016, that rate increased to more than 7 per 1,000 live births. And this does not include spontaneous abortions related to either drug intoxication or withdrawal, or the bevy of newborn complications that arise from primary or secondary effects of drug use or withdrawal and the medical and psychiatric comorbidities. You see an increase in cases between 2000 and 2012, with an 8 times increased length of hospital stay and 10 times cost. And of course, in 2013, Kentucky had the highest rate of NAS in the country. You also have a rise over time, kind of concomitant with the drug epidemic in sexually transmitted infections due to risky sexual practices. There's some evidence that the rate of fatal car accidents has increased. This September 2017 study shows a 7-fold increase in related fatal car accidents from 95 to 2015. Incarceration and legal issues are another part of the kind of widespread nature of this problem. And then also a decrease in our annual workforce participation rate, ability to contribute to society. And so I'm going to quickly run through a couple of solutions and then kind of open it up to the group to further discuss. So first and foremost, we really have to treat addiction like the chronic disease that it is, with an emphasis on prevention, an emphasis on acute treatment, chronic treatment, and then maintenance treatment. I think it starts with trying to avoid the use of stigmatizing language. For example, I had a patient that got upset with me one time because I used the term drug abuse, and they very accurately pointed out that when you compare that to something like child abuse, right, that is where another person is abusing a child. In reality, the drug in this case is abusing the patient. So I know it's just a word, but words can have powerful consequences, and developing that rapport with the patient is so important early on. This graph kind of gives you a contextual framework for how there is this entire kind of shared responsibility at different levels, including individual, interpersonal, the community level, and the societal level. This is one of my favorite slides that I've seen in terms of treatment. I just love how it breaks down patients into 3 categories. I think so often when a patient comes in and does not want to stop using drugs, there's an immediate visceral or even unconscious reaction to that, okay, well, I don't need to do anything. No, there's a whole host of treatment opportunity there in terms of mostly education, but a lot of harm reduction measures. And then the more willing somebody is to get treatment, the kind of more preventive and abstinence-based care you can provide. This is probably a little bit grainy, but these are some really well-proven harm reduction programs, including widespread Narcan distribution, needle exchange programs to avoid a lot of the infectious complications, pharmacies being allowed to sell needles and syringes, as well as widely available medication-assisted treatment. There's still huge proportions of the population who don't have access to this, a lot of misinformation about it, legalized or safe injection houses, and then the safe disposal of unused opioids. These are some recommendations in terms of post-surgically, how to how to prescribe opioids. And so setting expectations and norms, using as many non-opioid options as possible, as well as really emphasizing the adverse effects of these medications. Just some other ideas, I think: decreasing stigma, increasing awareness, continuing to educate everybody that we can about this problem, preventive measures. I think it's important to hold the pharmaceutical companies, distributors, pharmacies, physicians accountable, increase the access, as we said before, collaborative care models that emphasize mental health care as well as addiction care. And then, this idea of legalizing or at least decriminalizing drugs. We've seen in Portugal, who decriminalized back in 1999, or maybe it was a couple of years after that, has had a huge reduction in deaths, HIV or infectious complications, as well as incarcerations. So with that said, these are some sources. And I would like to open it up to discussion at this point and kind of hear some of other people's thoughts on possible solutions.
Hello, Ethan.
Yes.
First of all, a very good presentation. Could you comment on Suboxone versus methadone as far as long-term management? Which do you prefer and why?
So I didn't have enough time or room in the slides. I initially wanted to include, some slides on buprenorphine. I think Suboxone is something that's widely misunderstood in the general population. I don't think there's enough people that understand that if a patient has Suboxone in their system, even if they use on top of it, they are much less likely to overdose because of the strong binding affinity and the lack of heroin and fentanyl being able to latch onto that opioid receptor and cause respiratory depression. For that reason, I prefer buprenorphine over methadone. I think methadone, does have benefit. It's been shown to have benefit, but there's no max effect with methadone. And there are people who still overdose and die from respiratory depression related to methadone. As well as there is some good kind of recent evidence that buprenorphine might actually, to go back to one of those slides before, appears to be a lot safer for pregnant patients in terms of outcomes, length of hospital stay for neonatal abstinence babies. So it's a tough kind of question to answer. I think a lot of people in the addiction community have a problem with replacing one addiction with another. And I struggle with it myself because it's not like Suboxone is devoid of side effects. But the reality is, if you take 365 days out of a year and you do really well in terms of battling your addiction for 364 of those days, and then you have one day where you purchase even something like a Xanax from a illicit drug dealer or somewhere where you think you're getting a decent drug supply, that could kill a person if it's laced with fentanyl. So is maybe a mild reduction in quality of life over 364 days, is it worth having that drug in your system the whole time in case that 365th day you happen to unknowingly or knowingly use fentanyl or some other opioid that could kill you? I don't know.
There's a difference between addiction and dependence. And I think that you're replacing an addiction with a dependence. And it doesn't necessarily have a lot of the life-altering effects that using something that's not approved or controlled would have. So essentially, you're replacing something that could kill you with something that's very unlikely to kill you, something that's life-saving. People are dependent on lots of things. People who have diabetes are dependent on insulin. I'm dependent on oxygen. You could be dependent on a medicine and have no moral sort of a problem with it. Yes, I can.
Right. I sometimes with patients, I will use the example of, you can eat 10,000 calories a day and it's not healthy for you, but you could eat 10,000 calories a day of McDonald's, or you could eat 10,000 calories a day of fruits and vegetables and healthy grains and et cetera, et cetera. Dr. Stewart, you should be able to answer your question.
I've got a question. I got in trouble for not raising my hand last time in Grand Round. So I was trying to raise my hand. Great presentation. I caught, I think most of it. I got a question for you though. Okay. So, I've heard from some people who've been working in the field a really long time, an interesting idea that I got to say I can't just dismiss, and that is, should we be treating accidental overdoses? And I think a lot of the information you give sort of compels someone to consider this. So I want your comment on it. Should we be considering accidental overdose victims, or people who commit accidental overdoses and then get treated medically for that? Should we be treating that as a suicide attempt? And these patients do have impaired judgment and are significantly at risk of death, much more sometimes imminently than our even high risk psychiatric patients. So shouldn't we be thinking about in those terms with these patients? And I also think that the other thing, if your presentation also does speak to the idea that addiction really is a problem for all of medicine, and really argues for the widespread adoption of medications for opioid use disorders by all specialties, and encourages everybody to get waiver trained for Suboxone. Not that that's the only answer, but to get involved in addiction treatment. So, but I would be interested in your thoughts about treating accidental overdoses as suicide attempts and using the system that we have for treating people involuntarily in that regard. Just go ahead, wax on. Thanks.
Yes, I 100%. I think we need more Narcan, more Suboxone, more fentanyl test strips, more needle exchange programs. I'm a proponent of safe injections, et cetera, et cetera. I think we've kind of failed in our ability to stop the influx of illicit drugs into this country, and especially now, I don't think we're going to be able to curb that problem. In regards to depression, I think we should have a very low threshold. I don't think it would be a bad idea to, obviously, if somebody is stating it was a suicide attempt, we would see them in our in the current state now. But maybe we need to reach out to collateral and get collateral information for non-fatal overdoses to see if there's any if there was any intent for self-harm, whether that be suicidal intent or just self-harm in itself. I think having a really low threshold for that is important moving forward. And even if it's not related to suicide, offering that patient the opportunity to see a provider from a substance use disorder background or an addiction background, I think is really important. Offering that up for everybody, trying to educate patients on the fact that we don't necessarily just offer medication assisted treatment, but having the ability to go into that emergency room bay where the patient wants nothing to do with treatment and just saying, hey, I'm trying to meet you where you're at. I think it's important you know the infectious risks. I think it's important that you know where to get these different harm reduction treatments, such as needle exchange and test strips, et cetera, et cetera. So yeah, I mean, I don't see how that would be problematic in any way. I think that could definitely help to stem the tide. That answer your question?
Yeah, thanks. I just wanted to, get your comments on it. I mean, there's obviously, it'd be controversial and there'd be logistical problems with it, but I do think there's a compelling argument to make that these patients are impaired and in danger, in imminent danger of death. And that qualifies them, I think, in a lot of ways for the same kinds of assessments we're doing in emergency situations for other patients where we place them in involuntary treatment. And that would be difficult to do in our current system because of the resources. But is that really an excuse to not consider that? And it so shows up and it costs us a lot. And it's not something you can put a Band-Aid on, or it's not something that medications are going to solve just by themselves. You described well a comprehensive approach, which we still, even after all this money, we still lack a real solid infrastructure to handle. So anyway, thank you.
Thank
I
you
would
for the
wonder
question.
what the recovery rates for compelled treatment would be. And my guess is that it would be a lot lower than someone's response rates to treatment if they sort of showed up of their own accord, or even if it was uncovered during the course of your working with them.
Coerced treatment has about as good a rate as voluntary treatment. Most patients are coerced into treatment. So I would challenge that notion. But yeah, it's a good,
You're more of an expert than me.
Well, and it still offers the opportunity to educate on harm reduction measures too. Even if, again, they're not willing to hear anything about cessating their drug use, it gives you the opportunity to get your foot in the door and have that initial discussion and hopefully build a little bit of rapport that can, later maybe lead to better outcomes. I've got a question on here from Dr. Marcellus. From your experience at New Lease, have you noticed any aspects of outpatient practice from the provider perspective that hinder patient improvement? What would you like to see added change to the current practice model to reduce mortality rates and improve patient outcomes? So what we're trying to do at New Lease is kind of, work within this collaborative care model. I kind of see it as the best of both worlds. And when I say both worlds, I mean the kind of classic AA abstinence-based model and the newer medication-assisted treatment model. I don't think AA-based solely works for everybody. And I also don't think 30-day prescriptions of Suboxone without much intermediate follow-up in a person who's using drugs multiple times a week or multiple times a day is particularly effective. So I think, having very close follow-up initially and accountability. We are doing confirmatory drug tests on every single patient every single time. So we know exactly what is in their system. They start out coming twice a week. If they're able to provide clean urines for a significant period of time, that moves back to every 2 weeks and eventually monthly, but also open up availability for psychiatric care and primary care. So I think this collaborative care model is hopefully gonna help kind of surround these patients with services and reduce the overall morbidity and mortality associated with it. But who knows? We're still peaking here, and it's a little heartbreaking. But I'm out here on the mountaintop yelling as loud as I can. I don't know if it's helping a whole lot, but hopefully it's moving the needle for some people to at least consider this problem with the severity that I consider it as.
Awesome, thank you. I know from what I've heard, it sounds like you and Stephen Love are making a lot of good changes over at New Lease. So keep up the good work.
We'll see.
Dr. Short, I just wanted to thank you so much for this really comprehensive review and also sharing your personal connection to this too, because I think a lot of us have that in some degree. And really, this is more of a comment than a question, but talking about the non-fatal consequences or sequelae of overdose, I think is really important because it's not discussed all that often amongst clinicians, especially in the psychiatry world, I think. But really, I mean, it's something we see all the time over at the substance use disorders consult service on our SUDS team. I mean, horrendous morbidity and mortality from things like endocarditis, septic emboli. And I think patients also don't really know about these risks too. Like pretty much everyone I talk to, knows that they can have respiratory depression and death from potential opiate use, but not a lot of people have ever heard like, oh, I could become paraplegic from having an emboli to my, spinal cord, or I could have a heart infection. People just don't, I think, really think about those types of things. So, opening up this discussion for clinicians and the general public too, I think is really important. Thank you.
Yeah, thank you, Dr. Wood. Just on that point, the slide that I showed in terms of my personal connection, it was just so important to me to add that in because Will's parents were open enough to discuss that at his wake, which I know is not an easy thing to do, but it's so important in terms of destigmatizing the illness and allowing us as more of a general population to talk about these things and not make it a moral issue or a judgment issue, but rather treat it like other diseases where the patient makes bad decisions and it causes worsening of their disease. We don't scold diabetics like people kind of react towards substance use patients. And so, I think that part was really important to have in here, and hopefully everybody kind of takes that away from this presentation to try to have more open and honest discussions, because I know everybody in this room right now has a personal connection to the drug epidemic. It's nearly impossible not to. You've got millions and millions, tens of millions of people that are directly affected by it, and probably hundreds of millions globally that are indirectly affected by it.
Great talk and a great discussion so far, I think. Going back to what Dr. Stewart said about involuntary hospitalization for accidental overdoses, I think in a way it's a little bit hypocritical when you consider that you're supposed to take an unbiased approach with drug use. And if a patient's coming to me and saying, hey, it was an accident, I didn't want to kill myself, I don't need to be locked up against my will, I don't need my rights taken away from me. I think if I do that, in a way, I'm showing them that I'm punishing them for their behaviors. And so just taking the fact that you want to take an unbiased approach, if I do that, then I feel like I'm not. And I'm saying what you did was wrong, and that you need to be in a hospital against your will because you are dangerous. And the patient would be like, well, that's not true. And so I think maybe it'd be harder to reach the patient in the long run if you did something like that.
Yeah, that's a good point. On the flip side of that, this is something Dr. Wood and I talked about before. Kind of on the other side of that coin is, there are surgeons who will refuse to do valve replacements on endocarditis patients. And where does that fall in this whole discussion in terms of forcing treatment? That's on the opposite end of the spectrum of somebody not unwilling to treat a patient just because they're making bad decisions. And it kind of, I guess in my mind, you can kind of put it on that spectrum of treating endocarditis or trying to treat that person who overdoses and then says it was an accident. Yeah, I don't know. I don't think there's a one answer to that, but.
Yeah, I think it's a good question for debate, though.
Hey, Ethan, if you don't mind me asking a quick question. First, I can tell how passionate you are about this. I can tell this is something that you really feel strongly about, which I really appreciate. From your personal perspective, I've looked into research regarding amphetamine use disorder, methamphetamine use disorder. There isn't really great pharmacological treatments out there. The best treatments seem to be like long-term counseling or abstinence programs. Have you seen any research out there showing any effective medication treatment, and what's been your experience?
No. Short answer is no. I think CBT is still the most widely accepted version of treatment, and it's the success rate is significantly below 10%. There was a study of Wellbutrin and naloxone, I believe, that had some better data, but I know Dr. Stewart and I talked about that, and kind of gave me the impression that it was not as strong as they presented it. I think there is something in the pipeline for like a monoclonal antibody against meth, or some sort of medication that will block the effects. I don't know how many downstream side effects that would have, or how clinically useful it would be. Yeah, I don't have a good answer to that. I know that a lot of us use Wellbutrin, but again, it's probably the hardest thing that, in terms of drug use disorders, I have the hardest time treating meth use disorder over anything else. Part of it is that kind of residual psychotic or psychosis symptoms that always seem to be revolving around persecutory delusion, and just very resistant to, doesn't seem to respond very well to antipsychotics, doesn't seem to respond too well to Wellbutrin. So, and granted, I've talked to patients who have overcome that problem. And, you know, I've got a couple of patients that in the future, I hope to ask if they would maybe lead a group with other meth use disorder patients, so that they all can kind of get on the same page of what they're experiencing and hear firsthand from somebody, hey, I've experienced that same problem, and now I have a reduction in symptoms, or I don't experience it anymore because I've had prolonged abstinence from it. But yeah, meth is, I mean, the rises in meth associated deaths are pretty extreme over the past 4 or 5 years, since the Mexican cartels have taken over monopolized the meth trade, and made it so much more pure. And so, yeah, I'm not sure what the answer is there, but certainly willing to try some new things, and hopefully get some sort of, anything more than 10% effective is going to move the needle in that field tremendously. So
Yeah, definitely, especially in the CBT aspect, meth literally damages people's cognition. It takes away the ability to reason. So how can you really do cognitive-based therapy over time, especially for chronic users? So I have heard about the monoclonal antibody, which is really interesting. I have to look more into that.
yeah.
I think that's going to do it for today. We're a little bit over time, so I appreciate everyone's patience and participation. Any final comments?
Just want to thank everybody for coming and watching the presentation. Hopefully you're able to take some good information out of it, and be able to at least change your approach to these patients, considering all the different medical and psychiatric comorbidities. And anybody who has any influence at our medical school, please get them to increase the hours of curriculum that discuss this broad topic of drug addiction. I think when I went through, we had, I want to say 1, maybe 2 hours of curriculum on this, and it warrants so much more curriculum hours than it's getting right now. So that would be kind of my closing comment there.